Welcome to episode 7 in Diabetes Health Matters, in our series looking at hormones, health and diabetes. My name is Dr Joan St John. I'm the host of Diabetes Health Matters, and this webinar series is sponsored by Eli Lilly and Company and Menarini, although they have no input into the content of the webinar series. Over the previous 2 episodes, we have looked at the changes that can occur when you are going through the menopause, the perimenopause, the menopause. We've looked at those hormone changes, and we've also looked at what you can do if you are living with those hormone changes and living with diabetes, particularly with some focus on racialized groups. In this episode, we're going to look at a different aspect of hormone changes and an intersection between hormone changes and diabetes, something called Polycystic Ovarian Syndrome. Now, you might have heard about it, but not know what it involves. But by the end of this episode, you will certainly know from our 2 fantastic experts what Polycystic Ovarian Syndrome is. And in another aspect, we will be looking at contraception as treatment, contraception in other forms, and why you might choose to use it, what the risks, what the benefits are. Once again, we're joined by these 2 experts who are multi-award-winning GPs with specialist interests in health equity, women's health, contraception, and many aspects of care of women. So I want to hand over to them as they take us briefly through hormone changes that can occur, how that can affect you if you're living with diabetes or at risk of developing diabetes. Once again, what you can do about it. So these 2 ladies are so concentrated on how you can empower people to live with whatever conditions they are living with, to have their best life. So I'm going to hand over to Dr Itunu Johnson-Sogbetun and Dr Aziza Sesay. Welcome back to this excellent series about hormones, your health and living with diabetes, with the wonderful Dr Itunu and the absolutely wonderful Dr Sesay, and the combination of the 2, which is just phenomenal. So we're really grateful to you for coming back and sharing your knowledge. But we're going to talk about something called PCOS, Polycystic Ovarian Syndrome. We're also going to talk about contraception and living with diabetes and how these things can intersect. So are we handing over to Dr Aziza first? Okay, because tell us about PCOS. What is that?
Let us talk about PCOS, the annoying misnomer, which means that the name doesn't really make sense. So basically, PCOS stands for Polycystic Ovarian Syndrome. Okay, so poly meaning many, cystic meaning cyst, so fluid-filled sac. Ovarian syndrome is basically a condition that has specific symptoms that come with it. Now, the reason I said that it's a misnomer is because of the diagnostic criteria not including polycystic ovaries. So you do not have to have cysts on your ovaries in order to be diagnosed with PCOS. That's one thing. And the second thing is they're not actually cysts. So I do have a little model that I often carry with me. The reason I'm showing you it is because, yes, these are the ovaries on either side. And essentially, when we talk about PCOS, it's where you get, and if you remember from the very first episode, I said that usually people are talking about, oh, we need to balance hormones and hormones aren't balanced, when our hormones are not necessarily balanced per se, they're regulated. In PCOS, we have a dysregulation. So our hormones are not doing what they're supposed to do, and then that's what causes the symptoms. So in order to diagnose PCOS, we follow something called the Rutherford criteria. So in order to get the diagnosis, we say that you need to fulfill at least 2 out of the 3 criteria. The first one being that you get the irregularities of your period. So usually a typical menstrual cycle is between 21 to 35 days. When you have PCOS, it's irregular and it's not following a pattern. And for some women, they don't have periods for several months. And we'll explain why that's important. The second one is that you have high androgens. So that's basically male sex hormones. So either this is visibly, so some people have symptoms associated with it, and this is where they may get symptoms of acne, hair on the face, on the chest, or on the back. Similarly, acne on the face, chest, and the back. They may have male pattern baldness and thinning of the hair. All of those are associated with the rise in the androgen levels. And we can do a blood test because there's some women who actually don't really have the symptoms, but you do the blood test and you see that the levels are raised. Now, if you have the two, the irregular periods and the high androgen, that in itself means that you have PCOS. If you don't have the high androgen, then you have the irregular periods, but you have polycystic ovaries on the scan. Now, what we mean by that is they see cysts on the scan. But as I said before, they're not cysts. What happens is because of the dysregulation in the hormones, insulin resistance, the raised male sex hormones, that has an impact on our body's ability to ovulate, to release the eggs. So we are born with all the follicles that we'll ever have in our lifetime. Now, every single month we have a few follicles that try to mature, and then one of them matures and releases an egg naturally. When you have PCOS, they try to mature. They try really hard, but it doesn't happen. Ovulation doesn't happen. And because the follicles are building and trying to release the egg, that's the appearance that we're seeing on the scan, hence the PCOS. So the symptoms can be from irregular periods, heavy bleeding, acne, weight gain, fatigue, pelvic pain, facial hair growth, hair thinning, something called acanthosis nigricans, which is where you have the dark patches on the neck, skin tags, and then there's an effect on fertility. The reason being, as I mentioned, it has an effect on ovulation. And all of this happens because of the dysregulation in the hormones, which then has an impact on the patient, and you get the PCOS, polycystic ovarian syndrome overall. Now, I think what's really important is that we look at the fact that we've said this, and we'll keep saying this throughout these series, one size does not fit all. We need to look at the intersections because you're getting the triad of hormones, you're getting the weight gain, fertility issues, and the blood sugar changes simultaneously. And so there are complexities in what we're able to prescribe to you as a patient, what contraceptive choices are best for you, which we'll elaborate later on, because they can directly impact your weight, your mood, and your glucose controls, the very thing that PCOS patients are struggling to manage. So we need to look at that. We also need to look at it with a health equity lens. Now, PCOS and diabetes are more common in Black women, sadly. I feel like every time we talk about Black women, it's always we're 3 times, 2 times, 4 times. We're more likely to develop a lot of these conditions. And majority of the times, even healthcare professionals don't seem to be aware of this reality, which then has an impact on our ability to manage the symptoms. Coupled with that is the historic mistrust with healthcare professionals. And this is based on a lot of the abuse and the use of us, our Black bodies in medicine without consent, really. And we can delve into that for such a long period of time. But this has an impact on us seeking help and trusting the medical professions. And also their cultural beliefs that then will have an impact on our ability, or at least our want, to take the medications that would benefit us, again, because of these beliefs. But we as healthcare professionals need to have that understanding. We need to have the cultural competency. We need to have the awareness about the disparities that exist within these different communities. And the goal is to understand the full picture so that we can give you safe choices, so that you can make the safe choices that can ultimately help to manage your conditions overall.
So, as always, we want to look for solutions. We want to look about what you can do to improve a situation, because we spoke about the intersection of living with this condition of polycystic ovarian syndrome, living perhaps with insulin resistance, living perhaps with increase in weight. What can we do about it? Because last episode we spoke about those 4 pillars which were so important to our lifestyle, that health-giving lifestyle. What can we do about PCOS in this context?
So it's really important to understand that the same lifestyle foundations that we talked about for perimenopause and menopause are similarly important in PCOS, because as we discussed, it's a hormonal dysregulation condition. And this is actually a condition that I live with. One of the things that I think is really important to understand is that even just a 5% weight change, so whether that's a gain or an increase, can impact PCOS hormonal symptoms. So a 5% weight increase can make symptoms worse, and a 5% weight decrease can make symptoms better. So this is why lifestyle is so important. And so when you go and see the healthcare professional and they're talking about lifestyle, again, I know sometimes it can come and feel like judgment. It's because the evidence is so clear about this, and we can't get away from it. So again, it's about nourishing your body with the right foods, and we talked about that in the previous episode. Building metabolic strength and physical activity and movement, all the different types of movement that we talked about. But resistance exercise is so important here because it can help to improve insulin sensitivity and metabolism, because when you're increasing muscle, you're working against the negative metabolic changes that are coming from the PCOS condition, which is, as we've discussed, the hormonal condition. Now, supporting your hormones with rest. We've talked about sleeping, which will help you regulate your hunger hormones and help you manage stress. But all the other things that we talked about in the previous episode about how to manage your mental load, nature, about, support and getting help, all the therapy that you might need to manage any existing trauma. So important. Now with PCOS, it's also really important that we talk about the clinical and medical treatment, especially about the treatment approach for the different aspects. Now, irregular cycles are not harmless. So in terms of fertility, they might have an impact, but not everybody is seeking fertility. But what I'm talking about in terms of the fact that they're not harmless is that if you go for a prolonged period of time without having a period, so we're talking about over 3 months, your womb lining can start getting thick, and that can increase your risk of womb cancer. So it's really important that you don't go more than 3 months without having a period if you have PCOS. And this can be dealt with in multiple different ways. So you can be on hormonal treatment, so as the pill or so the combined pill or the progesterone only pill or a progesterone only coil. But some people say, I don't want to take regular hormones. And what you can do is, if you don't have your period naturally and it's been 3 months, we can give you a progesterone such as noracesterone or Provera, medroxyprogesterone acetate, to take to induce a bleed. So you have to have a bleed induced at least once every 3 months. And this is primarily to protect your womb lining. So as I say, the options are, if you're not getting it naturally, this is something that needs to be treated because of protecting your womb lining from the risk of womb cancer. And as Black women, this applies to brown women as well, we have that increased risk of womb cancer. I've shared that I myself, at the age of 35, because I live with PCOS, I was shocked to my core when I was diagnosed with atypical womb thickening, which is the precursor to womb cancer. So it happens, and it happens in even younger women. So this is why I'm saying it's really, really important. As a medical professional, I was shocked that this would happen to me. So when I'm saying this, it happens, and so it's really important that we regulate our cycles. Now, excess androgens, this can be really tricky because, for women, you can get facial hair on your chin, acne, and the anti-androgen hormones can be helpful. So in a combined pill, so you can have a combined pill that has drospirenone and anti-androgen. Now we have drospirenone as a stand-on. Now it hasn't been tested in PCOS, but there's every suggestion, particularly with its impact in combined oral contraceptive pills that we've been using for years, that it might have an effect to improve the excess androgens that we get in progesterone. So that's That's a new medication that's now available on the market. So we have combined pills that have the anti-androgen. We have the standalone anti-androgen progesterone only pill. And then we also have things like spironolactone, which is also an anti-androgen that can help with some of the acne and excess hair and the hair loss symptoms. And that's another treatment approach that can be taken. Now, for metabolic health and the complications, so sometimes people take metformin to help manage the symptoms. It doesn't work for everybody, so it can be used. But also the new GLP-1 agonists can be used as well to help regulate weight management and help support health in PCOS. But it's really important because sometimes you need additional treatment for your skin tone. We talked about acanthosis nigricans, which is the thickening and the dark skin, that darkening of the skin that can happen with PCOS. Some of the hair, our hair is thick and curly, so you might need treatment that is directed at our skin, that people that understand our skin and hair type, to be able to help us with those symptoms. Unfortunately, a lot of those treatments are not available on the NHS, and sometimes you might have to go to a private care provider if you can afford it. But it's really frustrating that we don't have some of these treatments for the physical symptoms of PCOS, because it can be really disheartening for some patients and lead to psychological complications. And that is something that is not on this slide, but it's so important to recognize that there's psychological and mental health complications of PCOS. So all the things that we've talked about in terms of the pillars, but also, sometimes people might need antidepressants and medication to help support some of the depression and anxiety that can occur with PCOS as well. Dr. Aziza, was there anything you wanted to add?
PCOS in Black women tends to be diagnosed later. And part of the reason for that is that there are multiple reasons, but one reason is how the lack of awareness of the symptoms, the lack of awareness of what is not normal, because we tend to normalize the abnormal, because one of the symptoms associated with PCOS is heavy, painful periods, which again is sometimes classed as normal for us. Or we tend to be diagnosed with multiple conditions. We may have fibroids, put down our symptoms to fibroids, when actually we could also have the PCOS. So it's not necessarily that it happens at a later age, it's that we get diagnosed at a later age because of these factors. There's also the medical misunderstanding or dismissals when it comes to the symptoms. There's, again, the stigma that's associated. So oftentimes PCOS is associated with weight gain. And then there is, sadly, within the profession, there is that fat phobia and putting everything down to the obesity rather than the fact that there's something underlying in terms of the hormonal changes. So I just wanted to touch on that reality, because sometimes people aren't aware, and that's how it can present in the PCOS. So in the next slide, where we're talking about the reality of it not just being reproductive, because again, we often see hormones as, especially sex hormones, as specific to the reproductive factors. But PCOS, as Dr. Itunu mentioned, it has a big impact on our overall metabolic state. It increases our risk of type 2 diabetes because of the insulin resistance that's associated with the condition because of the hormonal dysregulation. We're then at higher risk of having high blood pressure and also raised cholesterol, sadly. We're at increased risk of developing the condition that Dr. Itunu, I believe, spoke about last time, sleep apnea, where we suddenly have episodes in our sleep where we don't breathe and then we wake up, and that then has an impact on our sleep, which then has an impact on our overall metabolism, which then has an impact on our weight gain. So if you're seeing everything hits the other, everything will have an impact on the other. And then there's the mental health challenges. I mentioned the fact that you get the weight gain, you get the skin changes, you get the hair. That can have an impact on you as an individual in terms of how you perceive yourself. It will then have a psychological impact on how you're perceived in the world. It then will have an impact on you developing anxiety, depression because of that, or depression because of the vicious circle of the weight gain. So oftentimes people associate PCOS with the weight gain. Not everyone with PCOS increases weight, but it is a symptom of PCOS which just keeps getting worse. So you gain weight, which causes insulin resistance, which then makes you gain weight, which causes worsening insulin resistance. So it ends up becoming a vicious circle. And that will then have a psychological impact on you as an individual, particularly if you're not getting the medication and support that you need and deserve. And then that has an impact overall. You're depressed, you eat more, you don't exercise as much. Do you understand? Everything has an impact on each other. And that's why we look at the person as a holistic being, the biopsychosocial model that Dr. Itunu mentioned in the couple of sessions before. And then the importance of womb cancer. Dr. Itunu has already said this. The reality is that Black women are twice as likely to be diagnosed with womb cancer at a late stage, and we're twice as likely to die from it. And one of the potential reasons can be associated with this. So many women sometimes normalize that irregular period where they're like, well, you know what? I'm lucky, actually. I don't bleed every month. And they see that as a positive thing, especially if their periods are heavy and painful and they don't have the realization or that awareness that not having a period is linked with then the uncontrolled overgrowth of the womb lining, which then increases your risk of developing womb cancer. So it's really important to be aware of this reality and having the treatments associated with it. There's so many people where we've spoken about this before in terms of hormonal phobia, where people are worried about taking hormones. But in PCOS, the hormone that we're giving you helps to give you that regular bleed or stop you from bleeding at all. So we don't have to bleed every single month, which again is another ideology within our community where it's like, oh, if we don't bleed when we're on the hormonal medication, then we are disrupting our natural, when that's not really the case. What we're doing is that we're keeping the womb lining thin to protect it, to prevent cancer from occurring. I know I've already touched on this earlier. I was a bit excited when I spoke about it, but yeah, essentially Black women with PCOS are more likely to experience weight gain or more likely to have the high blood pressure and the type 2 diabetes. And we often present with higher triglycerides. So that's a type of cholesterol, that's a type of fat, and also a higher BMI. And we're nearly double the rate of metabolic syndrome compared to white women. When we talk about metabolic syndrome, it's all of those conditions together: the type 2 diabetes, the high blood pressure, the raised cholesterol, the obesity. And it's really, really important that we look at the person holistically. As I said, the unwanted facial hair that can cause stress and distress, and then the hair removal measures that we use may actually not be good for our skin specifically. Say, for instance, the laser therapy that's out there. If you go to the wrong laser therapist who doesn't have the knowledge for skin of color, you can actually cause things like hyperpigmentation, so scarring that then causes long-term damage, which then will have a psychological impact on you. And I cannot stress enough the vicious cycle that's associated with this condition, and why it's so important that we raise the awareness on the options that are out there and also the long-term complications that are associated with it, so we can prevent them from happening at all.
Absolutely. I mean, it's a hormonal condition, but it's the metabolic consequences, signs and symptoms that are so impactful and so important really with this condition. Ladies, what can we do about this?
So one of the things that we talked about was reframing contraception as a treatment. Now, I know that a lot of people feel that when they go to the doctor with PCOS, all they are offered is contraception. But I hope that we've tried to highlight the reason, particularly if you're not having regular periods, why contraception is raised, because of the risk of, if you're not having regular periods and you're not having periods at least once every 3 months, the risk to your womb lining. Now, of course, if you are having regular periods, and there's lots of people who have PCOS who are having regular periods, then and you don't need contraception, then contraception is not the option for you. But for other people, the reason why contraception is suggested is as for that anti-androgen, for the excess hair, the acne problems and things like that. So there is reasons why contraception is offered as a treatment. And, you know, if you see that the therapeutic benefit that contraception can provide in treating PCOS, you can understand why it's offered, because I know that there's a lot on social media that is untrue, that tends to pose contraception as a negative thing. And now it's not for everyone, and there are limitations, and you have to discuss your personalized treatment option with your healthcare professional, but I think it's really important. But now, just thinking about contraception more generally, I'd like for us to think about the different types of contraceptions that we have here in the UK. So we have the hormonal methods, which are the pill, which is broken down to the combined pill, and the progesterone only pill. We have the patch, which in the UK is a combined patch, so it has estrogen and progesterone. We have the ring, which is like hands up for the ring, because it's not that commonly used, but can actually be quite effective. You don't have to worry about it. You can change it once every 3 months, I think, and it can be quite it's not like taking a tablet every day, so some people really enjoy it. There is the progesterone injection, and then there's the implant, the progesterone implant. Then there's the copper coil, which is a non-hormonal coil, and then there are the barrier methods, so the condoms, and then there's permanent methods like sterilization. But also there is the natural kind of rhythm method. The reason why we're sometimes a little bit hesitant about the rhythm method is that it can be quite there's a high failure rate, and that's because our body and our hormones change quite a lot. Stress can change our hormones, other experiences, and environmental factors. But there are certain apps that have shown a higher efficacy method. So if we would recommend that if you need contraception for preventing pregnancy, that you use one of the more reliable methods. But if you decide that you want to use the rhythm method, then I would advise that you make sure that you're using a system or program that has more validation and is more effective. I also always like to add this about the historical framework around contraception, is that there were 3 things in the last century that really made a change to our lives as human beings. And the first one is immunization and vaccinations, because prior to this, we couldn't expect that a child will live into adulthood. There was such a high chance that they will die of a childhood illness. And then the second thing is, of course, antibiotics, which meant that we were less likely to die from bacterial infections. But the third thing is contraception. And I say this because it really changed the trajectory for women. It meant that women could live their lives without fear of pregnancy. It means that women could enjoy intercourse. It meant that women could get their lives back and control their family sizes. So I think it's really important to understand the impact of contraception and how it continues to be really, really important in women's health. Now, we've talked about the benefit of the contraception choices in managing PCOS symptoms, but sometimes it can have a metabolic impact, and that is because it can increase, particularly the oral contraceptive pill, the combined contraceptive pill, can increase risk of blood clots, particularly in people with diabetes and obesity and high blood pressure. So, you have to balance the risk versus the benefit. And if you look at the different types of diabetes, so type 1 diabetes, if it's well controlled, most of the contraception options are suitable. And if you don't have any other complications like being overweight or a smoker, depending on your age, so there are other factors as well. Same thing with type 2 diabetes. If you are well controlled, then most options are good, but the combined hormonal contraception may need to be avoided if risks are high, particularly if you have other complications, if you're overweight, smoker, raised BMI, over 35. And then if you have a gestational history of diabetes that's in pregnancy, it indicates that you have a higher future risk of type 2 diabetes. But if you don't have diabetes at the moment, most methods are safe, but again, it would depend on your weight, what your smoking status, your age, and a lot of other factors, your blood pressure, and lots of other factors as well. So just looking at what we call the UK MEC. So this is the guidance on what the hormonal options are. So if you look at green being 1, no restriction, 2 is yellow, so it means the benefits outweigh the risks. 3 means that the risks usually outweigh the benefits, and 4 is red, which means an unacceptable health risk. So if you look at history of gestational diabetes, all of the methods are a 1. If you look at diabetes, sort of type 2 diabetes, copper is 1 because it's non-hormonal. All of the hormonal methods, if you don't have any vascular disease or kidney disease, is a 2. So the benefits usually outweigh the risk. Same thing for if you're type 1 diabetes, but if you don't have any complications, so kidney complications, retinopathy, neuropathy, so that's the complications in the kidney, complications with your eyes, complications with your nerves, then you've got 1 for the copper because it's non-hormonal, and 2, the benefits usually outweigh the risks. Now, if you do have these complications, then we would say that combined pill is a 3. So the risks usually outweigh the benefits. So this is why you need personalized guidance on what the best options for treatment for you are if you need contraception. But as you can see, most of the methods are fine. Now, there's a particular health warning. If you have significant kidney disease and you're sort of on needing dialysis or things like that, then it's a red. You can't have the combined hormonal contraception. And similarly, there's a new progesterone-only pill, drospirenone, which I mentioned earlier, that can be used because it's an anti-androgen. But if you have severe kidney disease, because it can increase your potassium levels, you also can't have this. So it's really important that you disclose any kidney history to your provider before starting a new method. So now I'm just going to hand over to Dr. Aziza to talk about hormonophobia.
Okay. I know that we spent quite a long time. Thank you so much, Dr. Itunu. That was very informative. We spent quite a long time last session talking about hormonophobia, but essentially what we're saying is that there is fear particularly within our community, around the use of hormonal treatment. Some of the distrust comes again from the fact that sadly there was a lot of experimentation and a lot of examination that was done without consent. There was previous medical abuse within our sort of community, and so a lot of people feel, well, I'm not going to use something that they're probably going to try and experiment on me, or that's why they want to prescribe it. So that is completely valid. That is based on factual history, but it's not something that will continue to this day. I just want to reassure anybody who's listening to this who is worried that that's why you're being prescribed it. We're not ethically allowed to do that. Absolutely not. But that's one of the reasons why people tend to fear or mistrust hormonal therapies. There's also a lot of myths and misconceptions, and I have to say, part of the reason why a lot of us medics are on social media particularly, there is definitely a plethora of misinformation online around the use of hormones, whether it be the hormones for the treatment of menopause, treatment of PCOS, or even contraception. There are loads of people who think that it's unsafe and it's unnatural, but actually when we look at everything, and Dr. Itunu spoke about the UK MEC criteria, MEC being the medical eligibility criteria, they have done extensive research, and absolutely it's not one size fits all. If you have a certain condition as well as additional, whether it be high blood pressure or kidney problems and so on, then we will not give you specific types of hormonal treatment. However, when we're looking at the vast majority globally, it is safe. And oftentimes people are worried that, oh, but it's unnatural, they're using synthetic. A lot of these things are they're derived from plants. And also, when the hormonal treatments were initially released, we did have very, very high doses that we're using in the past. And absolutely, those high doses were, dangerous in the long term. But now the doses that we're using are a lot lower than they used to be. And so, as I say, every time they're looking into the research and they're developing more and more ways that are safer. And it is not one size fits all. The
Amazing.
reality is that there is a representation gap. We don't have enough research on our on Black people in general. There's limited research because one, sometimes we're not included, but the other times we don't come forward because again we're worried about the misuse and abuse. But I cannot stress enough the importance of us coming forward in research, because a lot of these medications, they've been formulated but not necessarily not with us in mind, but not with our genetics and the factors that relate to us as individuals. So it's important that we partake in research, and again that plays a part in hormonophobia. And then the communication gap. So a lot of patients say to me that they go and see their doctor and the doctor just prescribes them the medication and they're not told why they've been prescribed that, how it's important, why it's necessary, what in the long term it's avoiding. And then that's why we've taken the time to explain every single aspect and why we're prescribing what we're prescribing, when we're prescribing it. But I cannot stress enough the fact that you as a patient are allowed to ask questions. Please know that you can ask questions. If something is not making sense and you're not sure, just ask. And you're not forced to take it. But at the same time, because I've seen this a lot as well, if you decide not to take it, please tell us. Please tell us as healthcare professionals. We need to be aware, because when we see that there's certain changes that's happening and it's not making sense because you're not taking your medication, we don't understand what's happening. So it's really important. Again, this is a shared approach. You are the CEO and the expert of your own body, and we can only help to manage it as best as possible if we share the management together in what suits you as an individual. Please don't fear the hormones. There are loads of myths and misconceptions out there. Actually, for a lot of people, it can be life-saving, and we've already spoken about how it can be in terms of womb cancer.
Amazing. Thank you so much. So I'm going to let you just talk us very briefly through this final slide, because it's always about empowerment. It's always about giving people the tools that they can use to thrive and live healthily.
So I think all the things, we're coming to the end of this series. I think all that we've said is we want as a community for us to move from fear to empowerment. So educate yourself. Use reliable sources to debunk myths. So there's information in so many different formats now. I mean, Dr. Aziza has her amazing platform, Talks with Dr. Sesay, where she's constantly providing up-to-the-minute information on all sorts of different issues that impact women's health. And that is a safe and reliable source of information. But we have also all the different, we have charity like Verity PCOS who provides information. We have so many different, the NHS has the NHS website, for those who are, for the menopause, there's the Rock My Menopause, there's the BMS, Women's Health Concern website where there's loads and loads of fact sheets. There's so many different sources. So you can educate yourself with accurate information. Don't just look at a WhatsApp post and believe it. Test the source. And then the second thing is personal empowerment. Now, you are, as Dr. Aziza said so many times, you are the CEO of your life. You want to improve your quality of life. So we are the doctors, we as the nurses, we provide you with the tools in the toolbox. You're the one that's going to take the tool to improve your quality of life. I think it's really important to remember that you need to take ownership and responsibility for your own life. And also, trusted providers, go to culturally competent professionals. They don't have to be the same color as you to be culturally competent. They just have to be clinically curious, humble, respectful, and able to engage in shared decision making and listen to your concerns. So you want to go to people, and if you're going to someone you feel that they're not listening or they're not addressing your concerns, get a second opinion or even a third opinion. Open dialogue, share your worries with your doctors, with your nurses to build trust. And we mentioned as well about community. It's so important because we can't do this alone. Connect with others. Diabetes Africa is providing this platform, this community. This is a place where you can get your feelings validated and share your experiences, as a community. Can't have the health hour where they share information on a weekly basis as well on different health problems. So there's lots of places where you can go and listen to and build community and share experiences to make your health better.
Amazing. So I have to just thank you both. You are incredible, Dr. Itunu. inspirational and informative. Dr. Aziza, you've been awesome and absolutely amazing. The knowledge that you've shared that people can use to go, as I always say, each one teach one, to empower themselves to live healthier lives and to thrive in that healthier life, whichever phase of your hormonal life you're within at the moment, and whether you're living with diabetes, at risk of living with diabetes, and there's this intersection of the hormonal changes as a woman. We've given you, I think, the tools to have a foundation of a healthy life and to do what you can. I always love the quote from Dr. Maya Angelou, do the best you can until you know better. And I hope after this series, you know better. So when you know better, do better. Thank you.
Thank you so much for having us.
Thank you.
It's been a pleasure, absolute pleasure. Thank you. Thank you so much, both of you.
Thank you, Dr. Joan, and thank you, Dr. Aziza and Dr. Itunu. Dr. Itunu had to leave, but we will be continuing the discussion with everyone in the room. Thank you so much for your questions, for your interest around this topic that we don't hear enough about. So I'm going to pick up on a couple of points with you, but for everyone listening, do share what's resonating or what questions you have in the chat as you go. First question to both of you, I guess. Dr. Sesay made an important point earlier that many people aren't aware of the symptoms of PCOS, particularly in Black women, clinicians included, and that this can lead to women feeling dismissed. In those situations, what can patients do to advocate for themselves and be heard? And more broadly, what needs to change so we see a better understanding of these disparities across the health system, especially given the risks we've discussed? We've touched on this when we talked about being the CEO of your own body, but could you please expand a little bit on this topic? Dr. Joan, do you want to try? I think we need to bring up...
I'm here.
Yeah, she's there.
There's so many people on the call. You didn't see me. I look a bit different. I had to get changed quickly and run upstairs. My kids came home. Sorry.
Thanks. So what can patients do to advocate for themselves and be heard? And more broadly, a question about what needs to change in the system so that these disparities are reduced.
Of course. I'm so sorry about the background noise. My kids just came back. But thank you. That's such an important question. And this is something I'm extremely passionate about. First of all, I'm really glad to see so many of you who've joined this call, because that is the first thing that I would say in terms of how to advocate for yourself. You empower yourself with the knowledge. You gain the knowledge so that when you go to see your doctor, you're equipped. I hate to say that there are so many people who feel dismissed, who feel like they're unheard, unseen whenever they see their healthcare professionals. But when you go there equipped with the knowledge and you're able to advocate for yourself and you tell them what you think is going on, like you can make a list of things. Usually when we're taught as GPs, when we see patients, we are taught something called ICE, where we're supposed to ask you what your ideas are, what you think might be going on, what you're concerned about. So that's C, your concerns, E is your expectation. What is it that you would like us to do, whether that be an investigation or if you want us to refer you somewhere else? So knowing that we're going to ask you those questions, and if they don't ask you those questions, you can volunteer that. Doctor, I am concerned that I may have this condition and I'm worried because of so-and-so. I would like to have this assessment done, or I would like for you to refer me. And if you feel that the doctor is dismissing and saying, no, they're not going to do it for whatever reason, then ask them why. It is so important that you say why. You are allowed to ask questions when you see your doctor. You are allowed. This is your body. This is your health. And the final thing I want to point out is the importance for you to tell them if they say that they're not going to do certain assessments. And I'll say this as a healthcare professional, because I know that some of my colleagues, when this is said, they do think a little bit more. If you tell the doctor, okay, you're not going to do this test that I'm requesting, can you please document in my notes that I've requested for this test and you've said that you're not going to do it? Because if anything was to happen in the future and it's been documented, then that doctor could be called to question. So a lot of the times you say that question, they backtrack and they often will do the assessments. In terms of how to gain the knowledge, Dr. Itunu mentioned it before she left, attend these sort of sessions, attend the free health advice. Make sure when you're going online that you're utilizing reputable, scientific, evidence-based creators, because I know that there are loads of people now who are using YouTube, TikTok, Instagram, and so on to get their health information. And that's okay if you're using the right people. Make sure that their credentials are correct, and don't, like, if you see something and you're not sure and you think that it might be too good to be true, it probably is. I would encourage you, please, not to share it, because that's one of the things that we're doing, where we're sharing misinformation amongst each other. And in terms of how we can improve things from our side, I put my hands up and I say that us as healthcare professionals, there's a lot that we could learn and a lot that we need to learn. I know that in terms of the Royal College of General Practitioners, there are cultural competency training. So they're trying to improve things. They're trying to also improve our education in women's health, because again, it's lacking. We don't have enough. So there's a lot of improvement on our side in terms of education, awareness, so that we can manage patients better. And hopefully that will improve the overall outcomes.
Thank you, Dr. Aziza. Dr. Joan, did you want to add to what Dr. Aziza just said?
Not really much to add, because Dr. Aziza has dealt with that so fantastically. And the only thing I would say is something that we said in the first two episodes of this sort of series of hormone health episodes and living with diabetes, is that your individual changes are vitally important. As we've said in this episode, you are the expert in your body. So when you notice something different, if your periods are becoming irregular, if you are developing darkening of the skin, which you didn't used to have in a certain area, usually around the neck, as we've described in the episode, it's those sorts of things that you may notice, and those sorts of things that should alert you that things are changing in your body and you need to get them checked out.
And in order for you to know that is by knowing your normal. So another key phrase that we always say, know your normal. And that means that you need to do your checks. Check in on yourself. Understand what your periods are like, understand how they've changed, if they've changed, and go and seek help as soon as possible. Do your self checks. Make sure that and this is going a little bit outside of the topic, but this is important, and I really hope that everyone pays attention to this. Please examine your breast, examine your skin all over, examine inside your mouth, examine the palm of your hands, the sole of your feet, your nails. Also make sure that you're examining your genitals, examine your vulva, look in the mirror. There's nothing wrong with that. And for patients with diabetes, so there's some women who shave their vulval area, and I've seen a lady who shaved. She had diabetes. She used an old blade. She ended up having a severe infection in that area, a skin infection in that area, but she was too embarrassed to come forward because it was within those areas. And she also left it late. She didn't realize because she wasn't doing her checks. So the only way that we'll be able to find out whether something is wrong is if we know what is normal for us, and then we can pick things up early. And as soon as we see it, we go and see the doctor right away, because the hope is that if it does turn out to be something sinister, which is rarely the case, then the treatment is more likely to be curative, successful, and less invasive. So yes, thank you so much for that reminder, Dr. Joan. Know your normal.
Thank you very much. Dr. Joan, you said to one of our participants, Dawn, that we would go back to this question. Do you think PCOS causes diabetes, or do you think diabetes causes PCOS?
So I know we have the expert here, and I'm going to hand over to her. But in the chat, I said I think that the PCOS is starting earlier. The reason being that if we're not talking about living with type 1 diabetes, which can occur at a younger age, but can occur at any age, as we know from the first episodes in this series. If we're not talking about that, PCOS is developing from the time, almost like from the time you were born, from the time you were young. It may become apparent when you start having your periods or would expect to have your periods. So it becomes apparent and it becomes manifest at that point, but it has been developing for a period, quite a period of time. So I think it's important to realize that that has been developing in the background, even though the symptoms occur when you start to have your periods. So that's why I've said I think PCOS starts first, but they are definitely interrelated and they can definitely have an impact on each other. So PCOS can cause the insulin resistance, which that can then lead to pre-diabetes, as we call it. Non-diabetic hypoglycemia is the proper name for it, can lead to type 2 diabetes. And they, as I say, they're interrelated. But I'll allow Aziza to add more to that.
I love how you called me the expert. Dr. Joan is the Dawn. We all look up to her when it comes to diabetes and everything knowledge, but I'll just add on to what she said. So essentially, the two are interlinked, as she said. PCOS is interlinked with diabetes, especially when we talk about type 2 diabetes, and it's all to do with insulin resistance. Now, diabetes doesn't cause PCOS, and PCOS technically doesn't cause diabetes. However, it increases the risk of you developing diabetes. Both of them are linked with insulin resistance. Now, the issue is when it comes to PCOS, we do not quite understand why it happens in the first place. We know that there's a genetic element. We know that it can be sort of triggered by your lifestyle. Not necessarily the lifestyle factors is what's caused it, no. But if you have underlying the potential of PCOS occurring or the hormonal dysregulation occurring, then that's what then causes the PCOS. So your lifestyle will just trigger it to happen. But it was always going to happen in your case, if that makes sense, if you had the genetic factors. Also, there's a little bit of dysregulation, or the communication between the brain and the ovaries isn't as good. And that's why, again, you're getting the hormones doing whatever it wants to do, essentially. So the answer to your question is PCOS does not necessarily cause diabetes. However, it is linked with insulin resistance, which then can eventually increase your risk of developing type 2 diabetes. Type 2 diabetes does not cause PCOS. However, you can have insulin resistance, which can cause hormonal dysregulation, which then can trigger PCOS to occur. I hope that makes sense.
It does.
Thank you, Dr. Aziza. Another question that came through with regard to someone who would have started exercising and is following a reduced carbohydrate diet. What other factors might contribute to PCOS in that person?
I mean, just like what I was saying in terms of what causes PCOS. We don't know why PCOS occurs in certain individuals, but we do know that it can run in families. We know that there are some genetic factors. And again, we do know that there's some sort of disruption that's happening where the brain and the ovaries are not communicating as well, and where the body is getting the insulin resistance. And then we also know that because of the dysregulation that happens, the insulin resistance, you get weight gain. And because of the weight gain, you get more insulin resistance, and then it ends up being a vicious circle. So you're absolutely right. When it comes to PCOS, the top line treatment that we offer everybody is lifestyle. So it's not, we can give you medications and hormonal remedies and so on and so forth, the metformin, insulin sensitizing medications like metformin, but regardless of whether you're taking medications or not, or you choose to take some supplements, which there is a little bit of evidence in taking things like myo-inositol or inositol, because that helps to increase insulin sensitivity, they're not cures. We will always tell you the lifestyle is important. So exercising, and the NHS says do at least 150 minutes throughout the week. So that could be 30 minutes 5 times a week. And then make sure that you're doing at least weight training, strength training exercise. That's really good for your bone at least twice a week. You want to make sure that you're not smoking. And if you are going to drink alcohol, that you're not having more than 14 units across the week. Not in, some people hear 14 units, say, oh, okay, I'll just binge it all in one weekend. No, don't do that. That's really unsafe, and that's not good for you. Maintaining a healthy weight, which I know can be really difficult for people who have PCOS, because we know that the weight gain is not your fault. It's not your fault. I really have to stress that it is because of the hormonal dysregulation that you're getting the weight gain, but lifestyle changes can help. And then making sure that you're eating your fruits and vegetables. We've mentioned all of these in, I think it was the second session. Dr. Itunu explained this beautifully. Making sure that you're reducing your stress as much as possible through, the de-stressing things. So you can have meditation, doing Pilates, making sure that you're sleeping enough, making sure that you're doing things that give you joy, whether that's dancing salsa or hanging out with your kids, just something that makes you feel happy, increasing your joy in your life. Those are the main things that I would say are really important in managing PCOS. So to answer your question, until we get more research in women's health, because at the moment we only have 1 to 2% of the overall research when it comes to the funding, and then we find out what causes PCOS, it's really difficult for us to know exactly why it happens and why it affects certain individuals. But it is important that we know that majority of the times you're looking at the person holistically, and it's them in themselves, and treating them as a person to manage their symptoms.
Mm. Thank you. I wanted to ask a follow-up question to Dr. Joan, because there was a related question that sounded that it could be a lot of people's experience. For women who are already making lifestyle changes, like exercising, adjusting diet, but they're not seeing improvements, what might be going on in those cases, and how should that be approached? Dr. Joan.
So I think, we often say it's about person-centered care and person-centered advice. And I would ask that person, in terms of what they're doing, is that all that they can be doing? And we have given lots of different bits of advice, the 4 pillars that we've spoken about throughout the episodes, which are going to work and going to have an impact, different impacts for different people. So for some people, I've found that exercise works magnificently. And being active, doing the strength training, the resistance training, that can be the thing that it is particularly effective for that individual. For others, it might be changing their diet and adjusting, amending, adapting their diet, and that might be the thing. For others, it's sleep. I think we underestimate the health-giving effects of sleep, to whether you're living with PCOS, whether you're living with diabetes, a lot of different conditions. It can be really, really a wonderful treatment, I can call it, for those conditions. So we have to look at the individual. We can't give a one size fits all. And I think Dr. Aziza said this already this evening. One size will never fit all. We look at the person in front of us. We say to you, are you working shifts? Are you having difficulty managing all the things that are asked of you? Is that the case? Are you moving, a lot? Could you move more? So I think it has to be an individual, person-centered advice.
Thank you. And I see Dr. Aziza nodding. Thank you for this. And all the people in the audience agree with what you said, Dr. Joan. We've had a question on supplements like inositol, often discussed in relation to PCOS. Are these generally useful? Is there any evidence around these supplements, Dr. Aziza?
Yeah, so I did just touch on this, didn't I, when I mentioned inositol and myo-inositol. So the truth is, we as doctors are not allowed to prescribe supplements, okay? And we're not allowed to necessarily say to a patient that you should take this. However, what we know is that there's very minimal evidence, and mostly anecdotal stories from patients who have said that inositol has been helpful for them. And I've had patients who've said to me they took it and they had been struggling with fertility, and they found that actually it helped to regulate their periods, and then they ended up getting pregnant. We know that there is some very little evidence to show that inositol helps to increase insulin sensitivity. And if it does do that, then we know that that helps with the hormonal dysregulation. So it helps to regulate the hormones better. And then for some people, that then helps them to ovulate. However, there are side effects taking inositol. Some people have found that if they take it, it can make them feel really bloated, and they get really bad flatus, and they're literally farting all the time. So it's one of the side effects of it. Just be careful where you're buying your inositol. It's not supposed to be expensive. There's some brands that make it look really, really pretty, and it literally contains the same amount of inositol as a cheaper version that may not be as packaged lovely, and they don't have as much marketing. So it doesn't have to be the most expensive thing. If it works for you, great, but I cannot guarantee that it will work, because like I say, there's not enough evidence as at now for us to encourage you as patients to take it. But there is no harm in considering taking it. However, speak to your doctor depending on what your underlying medical history is, so we can make absolutely sure that it's safe for you to consider trying.
And I imagine, Dr. John, you'll say there isn't one size fits all.
Well, I think Dr. Aziza said that in another way as well.
Thank you for this clarification. We'll take a couple more questions and then we'll bring the episode to a close. Thank you so much for participating. I've got to make some announcement to say that if you are joining us on your desktop, you may be seeing some polls coming up on the screen. Please take a moment to answer the questions that we are asking. They're very useful for us to report and understand better you and plan our next episodes. If you are on your mobile, you may have to swipe left or right. We just ask you if you've learned anything during the event series that you can use in your practice if you're a person living with diabetes or a healthcare professional. So take a moment to answer the questions, and we'll continue with a couple more points that were made. Are there any links? Might there be any links between patients having foot issues and PCOS? Dr. Aziza or Dr. Joan, any links there?
I don't know that there is a specific link. What I do know is that if a patient has diabetes with the PCOS, we know that there are conditions and damage that can happen with diabetes. Obviously, that's why we have the regular foot review, because you can have neuropathy, so nerve damage, and you can also potentially have a high likelihood of infections and so on and so forth. So that's the only link that I know of. I'm not aware of anything specific exclusively to PCOS.
Not exclusively to PCOS. The intersection between PCOS and living with diabetes. Diabetes can predispose you to, as well as the neuropathy, as well as the vascular problems, the circulatory problems that we spoke about. Tendinopathy is another thing that it can predispose you to that people don't always recognize. So things like the frozen shoulder, the things like what we call plantar fasciitis, when people have pain in their feet, and that can be associated with diabetes. We know that there is this interlink between the PCOS and usually type 2 diabetes. So in that respect, but no specific one symptom of the feet.
Thank you, Dr. Aziza, and thank you, Dr. Joan. Just to touch on some of the more complex questions, people ask questions about surgery or less typical symptoms. What are some of the most common misconceptions you come across with regard, say, to surgery, for example, Dr. Aziza?
You mean surgery as a treatment for PCOS?
I think we spoke about the removal of, say, for example, the uterus or other types of surgery that people might see as a solution or a way to address these symptoms.
So I know that some people think that we've mentioned with PCOS, it has to do with ovaries, right? So some people assume that because it's to do with ovaries, why don't we just take out the ovaries and then it should resolve the problem, right? But it's more complex than this. PCOS is not just a condition to do with the ovaries, even though that's in the name. In fact, if you guys watch out, within the next week or so, I believe they're changing the name now because it's led to so many confusions. And I've mentioned this in the earlier part of the session, because PCOS, you don't have to have polycystic ovaries to be diagnosed with PCOS. Now, the point is, PCOS is a metabolic disorder that affects the whole body. It's not just to do with the ovaries. You have the imbalance, as I say, with the brain that's connecting with the ovaries and telling it what to do. You have the issues with the insulin resistance. You have the weight gain, and so on and so forth. When we remove the ovaries, all that will do really is stop the production of the sex hormones or enough of the sex hormones. So the ovaries release estrogen, progesterone, and testosterone. Now, estrogen can also be produced a little bit by our fat cells and also by a gland that sits above the kidneys called the adrenal gland. But when we remove the ovaries and we lose those hormones, we then plunge ourselves suddenly into menopause. And menopause comes with its own barrel of symptoms, which can be extremely debilitating for a lot of people. And when you go through menopause in this way, where the ovaries are removed and they suddenly put you onto menopause, you then have the plethora of symptoms, which can be physical. So the hot flushes, the night sweats, the what we call the vasomotor symptoms. You get the aches and pains in your bodies. Again, these hormones that often is considered just reproductive, we have receptors all over our body. This is where you can get hair thinning because estrogen helps to supply the hair. You notice the skin can get dry. We also put ourselves at a higher risk of developing heart disease and heart attack because we lose that protective element from things like estrogen that helps to prevent heart disease and so on. And we're already at higher risk when we have PCOS and if we also have diabetes, and then that increases the risk even further. We can get symptoms like genital urinary syndrome of menopause, which is where you're getting irritation in the vulval region, thinness, what we call vaginal atrophy, dryness in the vagina, increasing our risk of urinary tract infections, painful sex. And then it also comes with the psychological symptoms that are associated with menopause, from depression, anxiety, not being able to sleep, which could be because of the night sweats, which then has an effect on our mood. Like we've spoken about the importance of sleep. All of those, I think now there are about 70 to 80 symptoms that are associated with menopause, which I believe we spoke about in the very first session. And we delved into so much to do with menopause then. But the point I'm making is, removing the ovaries is not a treatment. It's not a cure. In fact, it can actually be more debilitating. There are other options, like we said, lifestyle being number one, and then the hormonal remedies and also the insulin sensitizing medications that are out there as well. And then again, similarly with removing the womb, that doesn't cure or treat PCOS per se. It might help if you have very heavy painful periods associated with PCOS, but you don't need to remove the whole wound for that. Again, there are the treatments, the hormonal remedies, which can help to manage the symptoms associated with that. So that's what I'd have to say.
Thank you.
Surgery might be a bit extreme.
Yeah, so I think this arose from some questions that have been in the chat, and I answered in some of that in the chat to say it depends on the indication, because somebody was asking about a hysterectomy and removal of the ovaries, but it really depends on the indication for the hysterectomy with removal of the ovaries. We would not consider that one of the options for treatment for only, when I say only, I mean the condition of PCOS only. So that's the only condition, because the reason being that there are other less invasive ways that you can manage the symptoms occurring with PCOS without doing a very invasive procedure of removal of the womb plus removal of the ovaries.
Thanks. Dr. Eva is asking a follow-up question. What about laparoscopic ovarian drilling in severe cases?
Oh, that might be a little bit outside of my remit. That's a bit too specialist because that's gynecological, if I'm honest. I'm not sure. I need to do some research on that one.
Thanks.
And as far as I know, the laparoscopic ovarian drilling has been used more in the case when somebody is seeking fertility, seeking reproductive ability, and sometimes that has been used, I know, in some settings. If we are talking about PCOS, other symptoms, and less severe symptoms, then as we say, we would be looking towards using less invasive treatments. That's my understanding.
Thank you. I hope we've answered or touched on the question you had, Dr. Eva. Would you like to ask anything, or would you like to comment?
Thank you, Greg, and
yes.
Thank you so much for the speakers. And I raised that because I've had a few patients with very young ladies in their early 30s or late 20s with severe polycystic ovarian syndrome and with the irregular menses, infertility. And we've sent them to, we work with some gynecologists who've actually done laparoscopic drilling of the ovaries. And the girls went on to get regular periods and conceive. And a good number of them had insulin resistance, so they were in the pre-diabetic state. And with modification of their diet, weight reduction, using metformin, they lost weight. And after the first baby, they had no other issues with their PCOS. So I've seen it in a number of cases. And so I was just wondering what your experience is in UK. Yep.
Thank you, Dr. Eva.
Yeah, that has been my experience, that it has been used more when somebody's seeking addressing their fertility issues with regards to PCOS, but I think it is less commonly used now in the UK, Dr. Eva, and that other methods are more used.
Thank you, John.
Thank you.
Honestly, I find this has been really, really fantastic. We have got in my clinic. I've had so many patients with PCOS, and a good number of them with high BMI. But a good lifestyle modification, weight reduction, use of metformin to improve their insulin sensitivity, their HbA1c come down. They feel so much better. Even the hirsutism disappears, and they're good. They get their fertility picks up.
Yeah.
So it's and we've seen it happen in so many patients. And the idea is, I like what Dr. Aziza and John, you say about involving, working together with the gynecologist. I'm an endocrinologist, diabetologist, and I've been in practice for over 30 years, and I've got so many of these patients in my clinic, over hundreds of them. And they do so well. They come with a fear: will I ever get a child? Will I ever get a baby? And that's the main fear. So by the time you take them through the stages, talk to them, then you get them getting a gynecologist, then they are told, and those who will need contraception to first regulate their periods to start with, they do it very well. Some of them are so scared because, as you said, about homophobia, the hormone scare that I'm going to get cancer, that is going to happen. And yet you have to tell them, if you don't treat, because not only can they get now the uterine cancer, but they are also predisposed to cardiovascular diseases, and they need to be told as early as possible. That education to me is very vital. And I seem to agree with everything that you've said, and I'm really excited to have joined this session today. Thank you.
Thank you so much, Dr. Eva. Thank you.
Thank you so much, Dr. Eva. And that sounds actually like a way to end this episode on a positive note, Dr. Aziza, right?
Oh, yeah, absolutely. Thank you so much, Dr. Eva, and thank you so much for everything that you're doing. I cannot agree anymore in terms of how we can all work together as a multidisciplinary team. I'm a GP and I have a specialist interest in women's health. I know my limitations, but working with gynecologists, with endocrinologists, with diabetologists, it can really make such a massive difference. So what we do is we make sure that when we're not sure, we share, we go on and ask advice and guidance to the next person, who then can give the patient the support that they need and deserve.
Yes, thank you. And Dr. John, having these conversations is so important.
Yes, because someone in the chat had said about healthcare professionals, do we need to know more? We always need to know more. We do continuing professional development, and that means we never stop learning. And my mum used to say to me, what, you mean that after you've qualified as a doctor, you still have to go and learn? And I say to her, yes, every day I have to continue learning. You have to keep up to date. You have to know what's out there. You have to know what's developing. And that's for all professionals. That's what we want to do. You can't be static. You have to carry on learning. And I always say, each one teach one. So Dr. Eva has shared with us, Dr. Aziza has shared with us, Dr. Itunu, Dr. Sioma, so many people in the chat have shared with us. We learn that way. We all benefit.
Thank you. it's time to close the event. Before some final remarks, perhaps from you both, I would like to thank you and Dr. Itunu on this really insightful episode, and thank you so much for your time and taking the time to answer these questions and opening up the conversation. We will be, Diabetes Africa is hosting on the 30th of April in London an event on diabetes and pregnancy. If this is a topic that is of interest to you this evening, please check out our website, www.diabetesafrica.org, and register, join the conversation, meet with our experts. We'd love to see you there in London on the 30th of April. And then I'll pass back the microphone to you, Dr. Joan and Dr. Aziza. Thank you so much.
Thank you so much. So first of all, I want to say thank you to Diabetes Africa for so professionally producing this webinar series. I want to say thank you to Mr. Diabetes Africa, as I call him, Greg, for moderating the Q&A session. Thank you so much, Greg. I want to say a massive thank you to Dr. Aziza Sesay and Dr. Itunu Johnson-Sogbetun, who have been phenomenal in the past 3 episodes talking about hormone health and living with diabetes. And you have been amazing experts. We are so grateful to you for sharing your knowledge. We are so grateful to you for all that you have given us. We really feel that in a privileged position to have learned so much from you both. It's a shame Dr. Itunu can't be with us this evening at this point, but I want her to know that we acknowledge her wonderful expertise, and you, Dr. Aziza, as well. So thank you so much. Thank you very much to the participants, the attendees who share with us, and we can learn from each other. Each one teach one. So we carry on learning, and we're doing a bit of a March Madness is what I call it. Next week, we'll be talking about research and the importance of research. So please join us again. If you have missed any episodes, if you want to watch them again, go to the YouTube channel and watch Diabetes Africa, where you can see Dr. Aziza, see Dr. Itunu, see Dr. Isioma, who joined us as well, talking about hormones and health. Thank you so much, everybody, and have a wonderful evening.